So, good evening, all, and welcome to the fourth edition of NOEL. Today's is session two. The initial first session we started with neonatal resuscitation up to date till 2024, and beyond that, probably the respiratory care ventilation. But when it comes, students always eagerly they wait to learn more and more from the faculties. So here today, the respiratory module, the first session we are going to start. So in the session, our focus will be to learn how to initiate ventilation when a newborn needs it. So through this presentation, Dr. Shweta, today's presenter, Dr. Shweta Chaudhary, she will present. She's a neonatal fellow from Marathali Rainbow Children's Hospital, Bangalore. So she will present today the session, a baby who is on ventilator. And the bedside presentation, come the presentation little bit about detail about the baby. And to guide her, moderator, I am welcoming Dr. Sandeep, who is neonatology consultant from Marathali Bangalore branch. So he's a senior neonatology consultant there. He has guided the student, and throughout the session, he will moderate again whenever needed. Today, two of the eminent faculties, neonatologists, join as expert faculty who will guide throughout the session, and they will lead the discussion here. I invite Dr. Sandeep Kadam sir. His eminent neonatologist, does not require any introduction. The senior neonatologist from KEM Hospital, Pune, and probably the country's all the neonatologists and students knows him pretty well. I welcome sir here. Sandeep Kadam sir.
Thank you very much, Dr. Nalini.
Yeah, very much here. Thank you, sir. Thank you for joining today. And another eminent faculty, my dear friend, Dr. Jagdish. He is additional professor in AIMS Bhubaneswar. So he is a well-known neonatologist in eastern part of India, and many young neonatologists knows him. He's a regular faculty of the many CMEs and workshops. So I welcome Dr. Jagdish for the session. So now I am handing over Dr. Sandeep sir and Dr. Jagdish to lead the session during the discussion. Dr. Shweta, you can probably start the session today. You can start your presentation, then we can switch over. Once the brief presentation over, switch over to bedside. Then the faculties, any point of time they feel to be interacted, they can start question and interaction and opinions. And in the meantime, request all the participants and students, trainees to post their queries and questions. So the faculties and moderator, we all will try to answer those questions along with the presenter.
Dr. Sweta is not audible.
Yes, doctor, you're audible.
Dr. Sandeep, you have to unmute yourself. Dr. Sandeep and Dr. Sweta, we are not able to hear you. Shweta, we are not able to hear you. Your presentation, case presentation, I can see the slide clearly. Dr. Sandeep, any Marathali, any issues? Because previously we hear you clearly. Any difficulty now?
No difficulty. I mean, I don't know. We just logged in again with the same thing. I'm not able to know why we are not able to hear. Just a second, sir. We will just sort it out.
We can see your presentation, not issue.
So can you hear me, sir?
Yeah, I can go to replay mode actually. This
Now you are
slides.
audible.
Yeah,
Okay, sir.
clearly. Go to slideshow.
Okay, sir. Good evening, sir. I'm Dr. Shweta, Neonatology Fellow from Rainbow Marthahalli. I'll be presenting my case today. Shall I start, sir?
Yeah, please continue.
Antenatal history. A 35-year-old G2A1 mother conceived spontaneously. A1 abortion was done at 15 weeks. MTP was done. And current pregnancy anomaly scan was suggestive of absent nasal bone. Mother has received 4 doses of dexamethasone in view of threatened preterm in the month of January. And mother was in preterm labor, that is 27 plus 5 weeks, and delivered by a preterm vaginal delivery on 14th of January at 2:18 a.m. with birth weight of 793 grams. Baby did not cry immediately after birth, and we have delayed cord clamp and shifted under the radiant warmer. The baby's heart rate was less than 100 per minute with no spontaneous efforts. Positive pressure ventilation was given for 1 minute and spontaneous efforts were present. Heart rate was greater than 100 per minute after starting positive pressure ventilation, and SpO2 was achieved to 90%. We have connected to CPAP support with PEEP of 5, FiO2 of 50%, flow of 8 liters, and shifted to NICU in transport incubator. Postnatal care, baby was brought in NICU and 2 doses of surfactant was given in view of increased FiO2 requirement and connected to HFO mode of ventilation. Gradually, FiO2 has come down to 30% and we have weaned down to conventional mode. Baby is now...
Dr. Shweta,
Yes, sir.
yeah.
Yes, sir.
Just
Yes,
can
sir.
you go back to the first slide?
Yes,
Just
sir.
before actually going to the baby, so let's have some discussion on the history part actually.
Yes,
So
sir.
what you need to tell me actually, the mother received 4 doses of dexamethasone on 18/1/19/1. So actually it is not clear at what gestational age actually the measure presented and why the dexamethasone. So that weeks you need to mention in place of dates. That will be easier for us because I don't know the EDD now. So how I can know what is the gestational age?
Yes, sir. It was at 23 plus 4 days of gestation, sir.
Okay.
During 23 weeks plus 4 days, mother came with the complaints of pain in the abdomen, and the scan was done. Antenatal scan was done in which it was showing that cervix membranes were bulging. And in view of threatened preterm, 4 doses of dexamethasone was given at 23 weeks plus 4 days of gestation.
So another thing just need to ask. So baby was delivered at 27 plus 5 weeks. Okay.
Yes, sir.
So what is the indication of second course of antenatal steroids here? Whether it was given or it was not given? Is it important?
Yes, sir. It was given, sir. It was given. Mother has come on 14th February. Mother has come to hospital with complaints of pain, labor pains, and second dose was given prior to delivery, sir.
Okay, so whether it was again the full course 4 doses or only 1 dose was given?
Only 1 dose was given.
So what is the recommendation regarding the second course of antenatal steroids as per the WHO?
Second course of antenatal steroids are usually if preterm delivery is anticipated within 7 days, we can give 1 dose of steroids, or in any 24 to 34 weeks gestation with risk of preterm anticipation is there, then we can give antenatal steroids. We can give betamethasone 12 mg 12 mg 12 mg 24 hours apart. We can give betamethasone. Dexamethasone 6 mg 4 doses 12 hours apart. We can give 24 hours prior to delivery.
Shweta,
Yes, sir. Yes, sir.
yeah. I think we all know the benefits of antenatal corticosteroids.
Yes,
Are
sir.
there any specific benefits of one over another in the developing countries like India, or there is no difference? Dexa versus Dexa?
Dexamethasone has a... In India, we usually give dexamethasone compared to betamethasone. First thing is the availability. Dexamethasone is easily available
Both the drugs
compared to...
available in Marathalli, you tell me which one will you recommend your obstetrician?
When both are available, then it is DEXA,
Why?
because it has, it is short acting and
No, but you want the steroid to cross the placenta and
yeah,
act on the baby, isn't it?
yes, sir. Yes, sir.
So, if both are available, is one preferred over another, or is it the same?
So betamethasone is not available, but if it is available, it
No,
is
no, no,
preferred.
both are available.
Both are available,
Tell me
then
which are available.
betamethasone is preferred.
See, now this is how examiners are going to ask you.
Okay, sir.
Basically, if you look at
Hmm.
betamethasone and in
Acetate.
India and betamethasone, which is available in the developed world, the structure is different. So
Yes,
that's why in our own country, DEXA is preferred over betamethasone. Number one, and the benefits are slightly better. Okay. What are the extra pulmonary benefits of antenatal corticosteroids in a preterm labor, or in a preterm baby?
Sir,
We all know
NEC,
it reduces RDS. We all know it reduces mortality. But are there any benefits apart from the lung development?
sir, it helps in protection from NEC, IVH, and from mortality and neurodevelopmentally better outcome with the antenatal steroids.
Anything else?
BPD, chances of
Sir,
BPD.
sorry to interrupt, sir. Some request actually. Sandeep, sir, your voice is low, probably due to the sound system there. Students are not able to hear questions, sir.
Oh, sorry.
Little louder, kind of.
Apart from
For you, the request.
apart from lung development, are there any benefits of antenatal corticosteroids?
Sir, NEC, sir, it is protective from NEC. Neurodevelopmentally, there is a better outcome, IVH, and decreases the mortality.
Good. Anything else?
Okay, Dr. Shweta.
Yes, sir. Yes, sir.
Yeah. Any other relevant information you want to give now before actually the baby is born? Any other history you want to give? Any intake of any other drugs that is helpful for the
Magnesium
postnatal outcome?
sulfate.
So you need
Magnesium
to
sulfate.
mention here, no? So whether
Yes.
it was given or not. Because that is important.
Yes, sir. Yes. 1 dose of magnesium sulfate was given 3 hours prior to the delivery, sir.
So what is the dose and what is the recommendation?
So 4 grams was given, sir, and through IM route, and it was given prior to delivery.
Yeah.
It is neuroprotective.
Okay, good. So I'll suggest here just add on important negative history. Okay, so that is
Yes.
also equally important. So why you feel this baby was delivered at 27 plus 5 weeks?
Sir, it could be because it was a threatened preterm. There were bulging membranes, and mother has developed a labor pains, preterm labor pains. It could be due to infection, sepsis.
So you need to tell that. So what is the cause behind the preterm onset of labor? Okay, and whether there is any features of chorioamnionitis that you need to know. Do you know what is the commonest cause of preterm onset of labor in our setup?
It is leaking premature rupture of membranes.
Mostly it is idiopathic, and second comes the stress. Then third, you can term it as the chorioamnionitis. Okay, next you go to the delivery. Next slide.
The birth history, sir. Baby did not cry immediately after birth, sir. So we deferred the delayed cord clamp, and we have shifted the baby under the radiant warmer. And heart rate was less than 100 per minute, and there were no spontaneous efforts. Positive pressure ventilation is
Yeah,
given
just a
for 1
second.
minute.
Just a second. Can you tell me here? So what was your anticipation at the time of delivery so that you can prepare yourself in the delivery room? So what you have anticipated when you are attended the delivery, what is your anticipation here? And
So,
how you are prepared the delivery room to manage those?
sir, this is a preterm delivery, sir. So the anticipated first is the temperature. We have to maintain the warmer temperature set at 36.5, and see that room temperature is also maintained at 25 degrees centigrade. And second thing is regarding the respiratory management. First, we have to arrange for the TP's resuscitator with the FiO2 of 21% and 21 to 30%. We can vary depend on the baby's condition. And with the PEEP of 6, flow of 8 liters, we have to keep the TPs ready. And apart from that, we have to keep the word surfactant ready since this is a preterm. And
So do you want to give surfactant in the delivery room? So what is the indication of delivery room surfactant? You told us, no? You want to keep surfactant ready in the delivery room. So in this gestational age, 27 plus 5 weeks, already 2 courses of almost received antenatal steroid. Do you expect the baby will need surfactant in the delivery room? And
it
if
is
yes, in
rare.
which conditions you want to give?
Sir, it is rarely indicated, sir. Mostly it might not be required. But in cases of where there is a pneumonia, or if there is any incomplete steroid coverage, that cases I would like to keep
But do you want to
the
give it in the delivery room or you want to give in a controlled environment in the ICU?
in the controlled environment, sir, especially in this case.
So this is 28 week or almost, no?
Yes, sir.
Okay. Okay, go ahead. So next. So
Next
during the
is
resuscitation, so you didn't tell about the anticipated problems. So you have to anticipate about the asphyxia, respiratory distress the baby may have. All these things should be your anticipation and you have to prepare as per your anticipated problems. Okay, so you can tell about the TPC, resuscitator, blender, everything as per that. Okay, so during resuscitation, what has happened here?
So during resuscitation, we received the baby. Baby's heart rate was less than 100 per minute. There were no spontaneous efforts. So baby was started on positive pressure ventilation, and it was given for 1 minute.
So what is the
And
starting positive pressure ventilation? So how you have given PPV here?
sir, the
You have,
FiO2.
hmm, hmm.
Sir,
Tell me.
we have set the FiO2 of 30% and flow of 8 liters, and we have given PIP of 20, and we have started the positive pressure ventilation, and we have given this for 1 minute.
So you have
After
given,
that,
so you have to tell it clearly. You have given for PPV through TP's resuscitator.
TP is resisted.
Okay, so you should mention that TP's resuscitator, and then what are the pressure requirements? So you told it is 20/6 with flow of 8 liters per minute and rate of?
Rate of 40.
Okay, go ahead. So then the spontaneous respiratory distress came down. Okay.
Yes, sir. Then the spontaneous efforts have come up, and heart rate has improved, and saturations have picked up. And then baby was connected to the CPAP support with PEEP of 5, FiO2 of 50%, and 8 flow of 8 liters with the RAM cannula, and then shifted to NSU in transport incubator.
So why you want to change the circuit again? So you have a TP's resuscitator, then why you want to give CPAP through the Ram's cannula in the delivery room again? Is it
So
a routine practice?
while shifting, we had to connect to the RAMS cannula, connect to the transport incubator, and then shift.
No, but you have a TP's resuscitator, na? So you have already used one circuit. So in the TP's resuscitator, can you give this amount of CPAP or you cannot give? Or it's a routine practice that you use Ram's cannula during the transfer? Just want, because it is a costly, na? Yeah.
Sweta, thing to clarify. Did you change your interface only from the mask to Ram's cannula, or did you change completely the TPC resuscitator and put on the CPAP, a standby CPAP? What you did when they transported?
We have
Because
changed.
only we use delivery room TP's resuscitator, the standard is with the mask. So transport time, you change the mask, put on the Ram's cannula, or you completely change what you did?
We have transport time. We have changed only from mask to RAMS cannula.
Same TP set you continued, but only the interface you changed because of transport. That's I understood from your description. Is it so?
Yes, sir. Yes, sir.
Did not change the machine. Did not change to another standalone CPAP machine. So you continued the same TP resuscitator. That's the way you were speaking probably.
Yes, sir.
Okay. Okay. Good. Next.
You are doing
Doctor,
well.
just to intervene, sir, Dr. Sandeep here. I think
Yeah.
she got confused. I just wanted to make a point here because we have a transport incubator which has a fixed T-piece, which has a fixed ventilator, but we also have a inbuilt T-piece into the warmer. So we cannot shift it with that. So we had to shift it to transport incubator T-piece along with the Rams cannula.
So every time you change the circuit, or how do you manage?
Sorry, we couldn't hear you, sir.
Every time you change the circuit, or how do you manage the circuits then?
The circuit is we change the circuit, sir,
Okay.
and we attach a new one and we shift the baby.
Okay, good. Okay, go ahead.
So little bit, I will take a privilege to ask a question here. When the same slide, Shweta. Just I will take little privilege. The
Yes,
first
sir.
sentence I have, baby did not cry immediately after birth, deferred, delayed cord clamping. You use the perfect word. Deferred, not delayed, deferred cord clamping. The current word is deferred cord clamping rather than delayed cord clamping. Meaning same, practice same. The word now preferably they are using deferred. So I want to understand, do we know or aware 2023 NRP recent recommendation of deferred cord clamping according to gestational age? Previously, there was a deferred cord clamping was there. Different gestational age was there. 2023, the ILCR guideline changed the recommendation. The audience will be more clear if you will tell, depending on different gestational age, what recommendation changed in 2023 December.
Not aware, sir.
So previous session of neonatal resuscitation, that the first point we discussed. So you did not attend that. For that reason, I'm asking, not for, because we discussed clearly deferred cord clamping, what the new recommendation. This is a 27 weeker. This can be a 29 weeker also. This can be a 33 weeker also.
Yes,
so
sir.
do we have a different guideline now currently that I'm asking?
No, sir. I'm not aware of.
Okay. I will expect the audience will post the question because previous session we clearly discussed about this. End of the session, we are going to answer this. Okay, you can continue. If the faculty is asking any question, you can continue the presentation.
So next slide, yeah.
Baby was brought in NSU, sir, and baby were required 2 doses of surfactant as FiO2 requirement was increasing, and baby was connected to HFO mode of ventilation, requiring FiO2 of 50% with MAP of 12 with rates of frequency of 10 and delta P of 20.
Okay. So
Gradually,
just need some clarifications here regarding, because it's a long course of 1 day you have told. So at the time of admission to the NICU, what is the status of the baby? One. Second, why you decided that the baby will be requiring surfactant? So is it mandatory that you need to give surfactant for this baby, or why you decided? Depending upon what criteria you decided that you will give surfactant, then the second dose of surfactant, when you decided to give the second dose of surfactant, at that time, what was the status of the baby? These two things I need clarification before we discuss about the putting the baby on high frequency.
Yes, sir. The baby required FiO2 of greater than 30% with the PEEP greater than 6. Baby was not maintaining saturation, and the Silverman-Anderson score was 4. So baby required higher FiO2 and higher pressure. So we had to give one dose of surfactant for the baby.
So what was your differential diagnosis for the respiratory distress at this point of time, at the time of admission?
My differentials would be, it could be a pneumonia or it could be pneumothorax.
You are giving surfactant, na? So it's a practice session. So it is not a marking session. That's I just asking. So you have to tell 1, 2, 3. So do you think pneumothorax will be the first cause or second cause? So what are the causes? Just this a preterm baby, 27 plus 5 received 2 courses of almost surfactant, 2 courses of antenatal courses, steroids, spontaneous onset of prematurity. So now you tell the baby was didn't cry after bath, resuscitation. So now you tell me about the causes. Which one you want to put as first? 1, 2, 3,
RDS.
4. Okay. So first is RDS. Very good. Second?
Pneumonia.
Okay. So why you want to tell it is pneumonia? So any positive points, negative points, can you clarify here?
Sir, it could be the baby was requiring higher FiO2 and higher PEEPs. There could be consolidation causing the distress in the baby. And there was also bulging membranes in the mother, leaking PV was there. So,
Leaking PV you have not mentioned here, no? So
sorry,
you can,
possibility could be there that antenatally mother didn't notice and baby, I mean, there was some leaking. So
no, if
that
there
could
is a
also be,
leaking, there won't be bulging membranes. Okay,
yeah.
so very rare. No? But what is
Yeah.
more correlating is unexplained preterm onset of labor. So
Mhm.
there you can think of some silent chorioamnitis maybe there. Okay, there may be no clinical features, but there may be some histological chorioamnitis that has gone into the labor process, started the labor process. Clear? So this is the second differential diagnosis. What are the other differential diagnoses for respiratory distress?
I think of pneumothorax
Okay.
and pneumonia pneumothorax, or it could be meconium aspiration, which is very rare.
At 28 weeks, you
Rare,
don't see meconium.
rare.
It is
Yeah,
mostly
rare.
beyond 34, 33 weeks. Less
Yes,
than
sir.
that, you don't see meconium. But what is more common? This baby has a history of asphyxia. Can it be related to that?
Yes, sir. It
Just
could
like a
be
secondary RDS like picture, it may not be a primary RDS, but because of
secondary
the
to
secondary to asphyxia, there may be a secondary RDS type picture. Okay, good.
oh,
So next, so what was your starting requirement? So what you decided? So baby was
so,
on CPAP, 6 and 30% you told. So you decided to give surfactant. So you need to tell us here. So what is the type of surfactant that you have given? And what is the dose that you have given?
Sir, we have given CuroSurf, sir, which
Very good.
is proactant alpha. It is
Okay, it's okay.
composition is proactant alpha. We have given 2.5 ml per kg. That is baby's weight is 793 grams. So that is 200 mg per
It's okay.
kg.
It's okay. So you have given that. So what was the response that you have seen after you have given the dose of surfactant?
After giving the first dose of surfactant, baby had apnea, sir. Uh, there was a brief period of apnea, followed by there was a gradual pickup in the saturations.
Okay, very good. So
And
what is the cause of apnea we thought of here at this point?
because the surfactant was, which we were giving from externally, was causing the block in the
Yeah, very good. So
uh,
maybe a partial tube block, maybe because of that. Okay. So what has happened to the ventilator requirements in terms of pressures, in terms of oxygen requirement of
after first dose of surfactant, the FiO2 requirement has come down to 25%, and the baby saturations have improved to 90%, 92%, and baby was maintaining about 4 hours. After 4 hours, baby gradually started desaturating. The saturations came down to almost 40 to 50%. We increased the FiO2 to 100%, but baby was not maintaining the saturation.
what are the
Uh,
different causes you thought of at this point? At 4 hours of life, baby requiring surfactant, baby improving, again deteriorating at 4 hours of life. So what are the
yes, sir.
possible 1, 2, 3, 4 again you tell me?
So one is leak. There is any
Okay. So
pneumothorax,
maybe pneumothorax 1.
or
Second,
pneumothorax, and hemorrhage, any pulmonary hemorrhage,
very good. Good.
and or ineffective surfactant administration. When the
Okay.
surfactant doesn't distribute properly, that could be one cause, and severe RDS sometimes.
Okay. So it maybe can be simply the CPAP what you are giving, it is not getting delivered. There may be some leak. That may be the simple cause. You are expecting that I am giving sick, but baby is not getting sick. Okay. Just can you tell me, I have not asked you, regarding you told that baby was on flow of 8 liters per minute when the baby was transferred. Whether you kept at 8 liter per minute or what was you told about the pressure and FI2 requirement, but you didn't mention about the flow. So what is the starting flow rate in the NICU when you put the baby on
5
CPAP?
liters. 5
Right.
liters, sir.
Very good. Okay. So what has happened? After 4 hours, what has happened?
After 4 hours, baby again started deteriorating, sir.
Yeah.
Shweta,
After
Yes.
Yes, sir. After
Okay.
4 hours, we have as I said, the baby saturations were dropping to almost it was desaturating, significant desaturation, hypoxemia was there. We had to intubate the baby and give the second dose of surfactant.
So
Okay.
before you
Any
give
investigation you have done to look at the cause at this point of time, or have you those investigations along with you?
We have done.
You thought of some 3-4 causes, no? So you must have investigated at this point of time. So do you have?
Yes, sir. I have done the chest X-ray at that point of time, sir.
Okay. So what you have seen in the X-ray? You are going to show us in the latter part in the during bedside. You have the X-ray here now.
Yes, sir. I have the X-ray here.
So
This was the X-ray after the first dose of surfactant. When baby deteriorated, we had to intubate and look for the X-ray, sir. And the X-ray was showing the homogeneous opacities on the right side more than left side with
yeah, correct.
this X-ray, you are happy
program.
with this X-ray? Are you happy with this lung expansion?
There is air trapping, so there's more.
So what will you do?
So I've given the, I have reduced, the I've given second dose of surfactant after this. And
No, Shweta, you have
Mhm.
achieved a good lung expansion and your baby is desaturating, correct?
Mhm.
So why did you give second dose of surfactant here? Or would you think before giving second dose, do you think we should cease for a few more things?
We have to, there are right-sided lung is not completely, it's still having the ground glass opacities on the right side of the chest. So, and baby was having significant desaturations. So considering that, I have
No,
given
our
second.
question is what are the possible causes? What are the possible causes of desaturation after you have given surfactant and the baby is desaturating? One dose. So you said pulmonary hemorrhage. You said it could be surfactant probably not given properly, or maybe it has gone in one lung. Apart from that, any other cause?
Severe RDS, which has not settled, or pneumonias.
Okay, infection. Very good. What else? You said the baby had not cried and you gave positive pressure ventilation. What is the effect
Pneumothorax.
of perinatal asphyxia in a baby with RDS who has received one dose of surfactant? Can it cause the baby to desaturate?
Yes, sir, it can.
What is the mechanism? How does it cause a baby to desaturate?
The when there is there is birth asphyxia, so there is the cerebral blood flow there's hypocarbia leading to
See, you are doing well. You are presenting well. You are absolutely doing perfect. Don't get nervous. We just want to know your thought process.
birth asphyxia leading to having an
Can
impact
it
on
affect
art.
the heart?
Yes, it can happen to the heart.
So what is the effect of asphyxia on the heart?
It will myocardial dysfunction will be there, and
Very
there will
good.
be hypotension.
Very good.
So
So what happens if there is hypotension to the oxygenation?
decreased oxygenation.
How?
Hypo. When there is no cardiac output, when the pumping is not good and the blood pressures are not maintained, so blood supply to vital organs is hampered, and it will lead to.
So there could be decrease in the pulmonary blood flow, or there could be right to left shunt because of systemic hypotension, isn't it?
Yes.
But also, if there is hypotension, it will cause acidosis, and acidosis will cause pulmonary vasoconstriction. Okay. Yeah, you can.
Okay, go ahead. You are given the second dose of surfactant.
And we have connected the baby to high frequency mode of ventilation.
So why you wanted to give high frequency mode of ventilation here?
Because baby was not maintaining saturations even after the second dose. So we had to connect to the and we have to connect to high frequency ventilation,
Are you
and we have
interested to know the CPAP pressures here? So that means you have decided that this is a CPAP failure. That's why you wanted to intubate this baby. So
Yes.
whether you have thought of increasing the CPAP pressures, how you decide it is a CPAP failure? Can you tell about that?
Sir, for about 4 hours, we have given CPAP prior to this. After first dose of surfactant, baby was not getting on CPAP support, so we had to intubate the baby and give the second dose of surfactant. And while connecting to the ventilator, we have set the HFO mode of ventilation, since this is a
No, just question is why you have chosen high frequency mode of ventilation in place of the conventional ventilation. You could have managed the baby with the conventional ventilation. Or have you tried with a conventional ventilation and you failed? That's why you have gone for high frequency. Just wanted
yes,
to know that. Yeah.
No,
map.
what Dr. Jagdish is trying to ask you, did you electively go to high frequency or you took it as a rescue after the conventional ventilation failed?
Yes.
We went up, we tried on conventional mode. Even on conventional mode, the pressure requirement was high, MAP requirement was more than 10. So we had to change to HFO mode of ventilation.
What was the effect at that point of time?
50%.
Okay.
Dr.
Just go ahead.
Sweta, just a little interfere here. Today's session is the main session of the today's learning session's main theme is how to initiate a ventilation in a newborn, a preterm or term birth. So you have intubated with the baby after declaring CPAP failure. So we intubated. Now, little bit if you clarify what setting, which mode, what parameters you set when you declared that this is a CPAP failure in intubated. People, student, all the trainees will learn how to initiate the ventilation. And the faculties also I will request little bit elaborate here because
Yes.
this session's theme is not for HFO learning. We won't go to HFO probably. So advanced sessions are there, but this beginning session, first session, I will just request both the faculties to go in detail when somebody chooses a pediatrician in front of a baby to initiate the ventilation, how to decide. But Sweta can elaborate this case and faculties can throw lights on this.
Yes, sir. Initially, we have started on conventional mode of ventilation, sir, with PTV mode of ventilation with FiO2 of 50% and PEEP of 6, PIP of
Sweta, just sorry to interrupt. PTV means for me is patient triggered ventilation. So you are started patient triggered ventilation unless you say the which specific mode. The trainees who are new beginners, as a I'm practicing long with many ventilators. PTV, if the SLE is in front of me, it is obvious. But if SLE not there, Marquez is there, Dragger is there, I will be confused with the name of PTV. So I want little clarity here. Just you tell me which mode and what parameters you set in front of the baby because
assist.
all many are beginners, so we are learners.
Yes,
So we
sir.
need little clarity.
Assist control mode, sir. Assist control mode we have started initially with the volume guarantee. So in this, we have set the FiO2 of 50%, a PEEP of 6, PIP of 20, and TI of 0.33. And baby was not maintaining saturation.
Okay. Okay, just wait. So how you decided that number of PIP of 20, TI of 0.33? PEEP, I could understand the baby is on CPAP of 6, so you decided PEEP of 6. But how you decided the number of PIP of 20 and TI of 0.33 for this 27 plus 5 will be? Because they will be.
Sir, the tidal volume we have set was not meeting, is not delivering properly. So we had to increase the PIP.
Shweta, I just would like to make few comments here. Whenever you have a baby who is extremely small with severe RDS, what is the mechanics that is affected when you are ventilating a baby? What happens to the compliance?
Less compliance is less in a RDS baby.
Correct. So compliance is very low. Is there any affection of the resistance?
No.
No. What happens to the inspiratory time constant in babies with RDS?
Short. It is short.
So when you are ventilating a baby who is preterm, you would obviously like the baby to be on a patient triggered ventilation. Number one, you may prefer a assist control, or you may prefer SIMV, but most of us are now going towards volume limit or volume guarantee, because we want to minimize the lung injury by preventing volutrauma. The degree of end expiratory pressure, as Dr. Jagdish said, we would be giving a slightly higher end expiratory pressure, maybe 6 centimeters, because the lungs are atelectatic. So you would like to prevent the atelectotrauma. While you are giving positive pressure ventilation, once you have intubated, you can look at your pressures which are required for chest rise to get an optimal idea of PIP. So it may be 20, it may be 18, or it may be 22. But more than that, I think you could look at the baby tangentially to see the degree of chest rise, and then you can decide your peak inspiratory pressure. As far as your TI is concerned, it should not be very high, maybe 0.35 is good enough for the air to go into the lungs, and your rates may be 35 or 40, whatever you want. The FiO2 depends on your saturation. So you have to have your target saturation between 90 and 95. So please remember that when you are initiating ventilation, I think these are few things which come to our mind as far as the initial settings are concerned. And then you can look at your saturations, you can look at your end tidal CO2, or you do a blood gas and optimize your mechanical ventilator settings. Make the baby more comfortable and don't handle too much. Maybe do a little bit of nesting, minimal handling, and look at the baby's pain, and you have an initial setting as far as the ventilation is concerned. Please remember, when you give surfactant, be there bedside with the baby to see the improvement in the lung compliance, because surfactant may take some time and your lung compliance gradually will improve, and you will see the same pressure giving you adequate or more chest rise, and then you will have to back out on your PIP. You can't go out for a cup of coffee leaving the baby bedside, otherwise you will end up getting a pneumothorax, right? Yeah. So here in this case, probably the four faculty that who are here may agree to disagree that not everybody would have taken the baby on high frequency from the word go. Probably we would have tried to optimize initial mechanical ventilation to see if the baby is getting optimal mechanical ventilation by using SIMV or conventional ventilation.
Sandeep, Dr. Sandeep,
Yes, sir.
probably there, I may request you a little bit to clarify, because directly
So we
the audience will
started-
get
I
directly
understand, sir.
connected to, may not be the case. And you may be the treating physician, you may little clarify, so the audience will be, the learning will be more clearer. I will request you just to clarify a little.
So we started when the baby got intubated, the FiO2 requirement was 100%. After intubation, we gave surfactant because the baby was saturations were not improving. And after that, we connected to 4 ml per kg of volume guarantee ventilation. The maximum PIP, we kept was 20 initially, but it kept increasing. When the MAP requirement went above 10, we shifted the baby to high frequency ventilation. But this change happened within half an hour, because the baby saturations FiO2 requirement did not come down drastically even with second dose of surfactant. The requirement was above 50% despite that.
I mean, fair enough. I think we really see that the baby probably was quite sick, and hence the treating physician felt that it was optimal that we should go on to high frequency ventilation. So there's no doubt about it that the baby was quite sick. Yeah, but I think this is how one should really see as to what are the initial ventilator settings and how we would start in a baby who has got severe RDS as far as initial conventional settings are concerned. Yeah. Okay, Shweta.
Shweta, Dr. Shweta, can you go to a bedside presentation, because you came now quickly. We can, if learn next 10 to 15 minutes, learn some bedside presentation quickly. Probably it will be useful for the, because faculties directly can ask about the baby. You can
Sir,
sort the baby.
Sandeep here. Sir, we extubated the child. Right now, the baby is on non-invasive ventilation. So I will switch over to Dr. Shweta here to this.
Yeah, she has noted here extubated to NIPPB mode, but did that presentation, if you directly she can do bedside, probably we can discuss on that later.
Sir, it's not allowed for us to share the. I think you have to stop the slide share. 1 second, sir.
Perfect, perfect.
Please go ahead. Shweta, please go ahead. Yeah, we can see the baby.
Yes, sir. Baby is currently extubated, sir, to NIPPV mode. The interface we used is a nasal mask, and as we can see, baby is nursed in an incubator cave with a set temperature of 36.5 with air temperature is 34.5, baby's temperature is 36.5, and baby humidity is maintained up to 80%, and baby's saturation probe is connected to the right upper limb, and temperature probe is connected to the connected on the right hypochondrial region, with babies having IV line secured on the left hand, and there are central catheters UVC and UAC inserted in the baby. UVC fixed at 6.5 and UAC fixed at 13 centimeters. And baby, the baby is connected to NIPPV mode of ventilation with FiO2 of 32%, TIP of 15, PEEP of 6, and TI of 0.45 and rates of 40. And baby saturation on right upper limb is showing 92% with heart rate of 138 per minute, and blood pressures are 37 by 18 with MAP of 25, which is between 50 to 58 cent. Baby is currently on inotrope infusion, noradrenaline, going at 0.2 mics per kg per minute with IV fluid dextrose infusions, and with TPN, and with antibiotics going on for the baby, and hepsilin drip.
How do you judge that the baby who is on non-invasive ventilation, you're happy to see that the baby is comfortable or baby is doing well? So how do you clinically judge the adequacy of non-invasive ventilation?
Sir, it depends on the chest rise, sir, work of breathing, and the retractions, the tachypnea, work of breathing, and the saturation of the baby prior to requirement.
Monitor the Silverman score, you need to monitor the breath sounds, color, perfusion, CRT, pulses, isn't it?
Yes.
Yeah. What care do you take when a baby is on NIV?
Sir, the baby is on nasal mask, so nasal injury should be prevented. So we should we should keep a watch on nasal injury, and the interface shouldn't become loose. I mean, it shouldn't get displaced. So we have to be careful with the interface, nasal interface. Whenever baby is moving or there is any alarm buzzing, we should be alert. And head cap and if there are any secretions, we have to take care of the secretions by keeping a watch on secretions.
Yeah, don't forget humidification of the uh,
Chamber,
not chamber, the
incubator.
the
Yes, sir.
respiratory system, because you
Yes,
are
sir.
giving NIV, so you may have to disconnect and put some saline drops in the nostrils, allow the
Yeah.
nasal passage to get blocked.
Yes, sir. Yes.
Suppose this baby desaturates suddenly. What will
Yes,
you
sir.
what are things that you will do, and what are things that you will check?
So displacement, is there any displacement
Very
of the
good.
interface?
Very good.
Or is there any obstruction?
Yeah.
Or is there any pneumothorax?
Mm-hmm.
Or is there any equipment failure?
So how do you check pneumothorax in such a small baby?
So trans illumination is one thing, bedside, which we can check. And auscultation, sir, in a decreased air entry on one side and
So
air
auscultation
entry.
before transillumination?
Oh, yes, first auscultation, then trans illumination.
Okay. The baby is on so many inotropes.
Only one inotrope, sir, noradrenaline.
Okay, okay, fine. Dr. Nalini, I need to join another meeting. Can I just leave? I'm sorry.
Thank you, sir. I understand, sir, the commitment, and you probably ask about various aspects of ventilation and IV. Clinical, we'd have been happy to see you for next few minutes, but your commitment, I understand. Thank you, sir. You can join there, and we'll continue a few minutes of the presentation and the queries. We will take audience participants' questions, and we will try to answer them. Dr. Sandeep there, Dr. Jagdish is there. Few minutes, Dr. Jagdish, me, and Dr. Sandeep will try to answer them. The questions.
Sorry
Thank you,
about
sir. Thank you very much. We'll
Thank
hope
you, sir.
that I also will see you later. You in that other some of the sessions of
Sorry, I had
ventilation.
a prior commitment. Otherwise, I would have not.
Absolutely agree, sir. So 8 to 9 o'clock we continue. That's perfectly fine, sir. Few minutes we will carry forward further. Thank you, sir. Thank you very much. Dr. Jagdish, few minutes. Can we continue?
Yeah, Dr. Sweta, just
Yes, sir.
so why you decided that the baby post extubation you want to keep the baby on NIPPB or CPAP? So why you choose NIPPB over CPAP here?
Sir, in this case, already we have tried CPAP.
Post extubation, after the baby was on high frequency ventilations. Okay, so I'm not coming into the settings. I hope the settings are minimal, and then you decided to a non-invasive mode of ventilation.
Yes,
so
sir.
at this point of time, so how you decide whether I'll put the baby on NIPPB or a CPAP or HFNC?
Sir, NIPPV has lesser extubation failure, sir, and lesser chances of reintubation. So compared to CPAP. So that's why I prepared non-invasive NIPPV mode.
Okay. So since so today, what is the day of life today for the baby?
40 hours of life, sir. 40 hours of life.
So in the setting of noradrenaline, baby on antibiotics, so can you still revise your diagnosis? Or do you want to go with the still RDS?
Sir, leading to second. Yes, culture sepsis could be sepsis induced.
So why you decided to start antibiotics in this baby?
Sir, there was cultures were showing growth, and
Today is 48 hours. So in backtech, so before you routinely send backtech for each and every baby, or you investigate then you start antibiotics?
Sir, we have sent culture on admission, sir, which was showing gram-negative bacilli growth.
Okay.
So for that, we have started the baby on antibiotics.
Okay, so since when the baby is on antibiotics?
So,
Since when the baby is on antibiotics?
so since day one, sir, day one, since admission.
So that's it. My question is that. So why you decided to start antibiotic on this baby? You are telling that blood culture is showing GNB, but before
Yes.
that you have already started antibiotics, na?
Yes,
So
sir.
what
Yes,
has
sir.
led to your decision to start antibiotics in this baby? My question is that.
Sir, this is an extreme preterm baby, requiring 2 doses of surfactant, and baby was on invasive mode of ventilation, and
So that means it is a prophylactic antibiotics, na? So there are
yes,
any symptoms you thought the baby is having any
uh,
symptoms? That's why you thought of
blood
starting
pressure,
antibiotics.
shock. Baby was in shock, sir. Initially, blood pressures were less, so less than fifth centile. So
So
that's
when
why
you
we have
detected at
started
what hours of life you thought the baby is in shock?
at 6 hours of life, sir.
Okay, so that time already both the doses of surfactant was given.
Yes, sir. Yes, sir.
Okay.
Both the
So we
doses.
hope that you have started antibiotic at 6 hours of life after the baby has gone into shock, I think.
Yes, yes, yes.
Okay, great. So now it is going GNB.
Yes, sir.
Okay, good. So just what is your plan regarding further ventilation of this baby? So how you want to continue? What is your plan? When you want to see the baby extubated, means deprong the baby from ventilator? So how you want to proceed regarding the ventilation for this baby?
Sir, if there are no further episodes of desaturation and baby is maintaining on this mode of ventilation without any apneas and without any distress, then I will plan to shift the baby to the CPAP support.
So what is your expectation? Till when the baby may require, when we can deprong this baby?
So from next 24 to 48 hours, we should be, if baby is not having desaturations and apnea, we can wean the baby to CPAP.
So next, so what are the things that you do now? So that is going to help you for the long-term outcome of this baby. Control.
Sir, we can give, we are already giving started from day one caffeine, sir. And we are feeding colostrum painting, and we are giving 1 ml second hourly feeds to the baby. TPN is going on for the baby. And we are avoiding all the kinds of noxious stimulus in the NICU and keeping as calm as possible. And septic protocols, we are following strict septic protocols. And
so what do you mean by developmental supportive care and what are the components? So can you summarize that for these? These are the 5 or 6 components of developmental supportive care and we are
sir,
doing these things. Is it important now for this baby?
yes, sir, it is important, sir. We have to avoid, we have to protected sleep to the baby, allow a protected environment for protected sleep and the pain management, and avoid all the noxious stimulus like unwanted noises and NICU, and family centered care, KMC, should be given to the baby, and healing environment.
So another thing, so for this baby, so what is your plan regarding caffeine?
Plan regarding family care?
Caffeine. You have started caffeine for this baby
Yes, sir.
occasionally.
Yes, sir. We have
What
started
is your
caffeine.
plan? So why you wanted to start here?
So this is an extreme preterm with immature brain respiratory centers. So high chances of baby going into apnea.
So you started it for prevention of apnea or for something else?
Extubation, prevention of extubation failure, and need to have a better neurodevelopmental outcome. And we have started the baby on caffeine.
What is the effect of caffeine on BPD prevention?
No effect on, not significant effect, sir. There are not much of
So, normally, sir, how much time we have now?
No, we normally have to go to 9 o'clock, but the discussion continues in question answer. We given another 15 to 20 minutes because
Okay.
9:30 the link till 9:30. But
Okay.
so as early as possible, the questions will finish to candidate. We can take the questions from the audience. 5 or 6
Okay.
important questions. We can take that. So is it over for the student, for the presenter?
Just two
Dr.
questions
Shweta?
I want to ask regarding her nutritional plan for this baby. Hello. So nutrition plan.
So we have started 1 ml second hourly. We have the plan is to increase the feeds 20 to 30 ml per kg per day, sir.
Okay.
Every day. If the baby is tolerating well, provided there is no abdominal distension or there are no bilious aspirates, and baby is accepting, tolerating well, and TPN is being continued. So
what is the plan for TPN? How much you want
once
to?
baby reaches, we are giving 3.5 gram per kg per day amino vein and 4 gram per kg per day SMOF.
You are giving lipid at 4 gram per kg per day.
2 now, sir, will increase to 4 gram per kg per day.
What is the maximum lipid amino acids you give?
3.
Okay. Normally we don't
3.5
prefer to
gram.
go to 4 point. Amino acids around 4 and lipid around 3 to 3.5. Probably we don't go up to 4 in case of lipids. So what is the targeted calorie here at this point of time? How much you target?
So 90 to 100 kilocalories per kg per day.
Okay.
So we have
Are you
to.
giving how much calorie? Have you calculated the amount of calorie that you are giving today for this baby?
No, sir. No, I have not calculated today.
Okay. Can you calculate now? So with the amount of TPN that you are giving, how much the calorie comes?
Okay.
So are you seeing something, watching to the close to the baby? Dr. Shweta?
No, sir. Calculating, sir. Calculating the nutrition. Sir has asked us to.
You can sow the TPN fluid and you can calculate quickly.
Sir, can we go away from the bed, sir? Is it needed that we need to be next to the baby?
If it's baby, go ahead. And from presentation directly in the slides where we're there, the first presentation session, we can go there.
Can come away from the view, no issue, sir.
Yeah, thank you. Thank you, sir.
Yeah.
Plus 18, 30 calories, sir. And, sir, we are giving about so we are giving about 50 to 60.
What is the minimum calorie?
Yes, sir. We are giving about 40 calories per kg per day, sir, currently.
Okay. So what is the minimum amount of calorie that you need for the basal metabolism?
Near about 90 to 100 calories per kg per day.
That will be for the growth. For basal, around 60 calorie, what you minimum need. Okay. So what other investigations you have done for this baby by this time?
We have done CBC
Hmm.
and we have done CBC, CRP. We have sent a blood culture, like I said, and electrolytes and calcium.
So suppose tomorrow in the morning you have seen this baby is deteriorating. Okay. So the FiO2 requirement has gone up to 50%. Okay. Pressure requirement has gone up. Okay. Inotropes requirement has gone up. So what are the different possibilities now?
When FiO2 requirement has gone up, inotrope requirement has gone up, then I think baby is in shock, or it could be sepsis induced, or it could be PDA leading to.
Very good. Sepsis, one. Second, PDA. Worsening sepsis means already the gram-negative sepsis is there. So it is worsening. One. Second, PDA has opened up. Two. What is the third cause?
Any it could be
Any scans you want to do for this baby?
neurosonogram.
So there may be a possibility of IBS also, because already the baby was asphyxiated, required positive pressure ventilation in the delivery room. Again, there are a lot of risk factors for development of IBS for this baby now. So there may be the risk of IBS. So you need to look at that part also. Okay. So how you are going to counsel the mother for this one? So I'm the mother of the baby. Just tell me how you counsel.
Hello.
So this is the last question I'm going to ask. So then we'll go to the audience questions. Okay. So how you want to counsel?
Hello, I'm Dr. Shweta, your neonatologist. And your baby is currently extubated to non-invasive ventilation. So baby is currently maintaining the saturations on this mode of ventilation with minimal distress is still there. And as you have to supplement the baby with the milk. So expression of colostrum and whatever milk is coming every 2 to 3 hourly, supplement the baby is required from your side, which can help the baby. And yeah, baby is we can start the feeds for the baby. Like I said, we need your milk. And apart from that, the regarding respiratory outcome.
I'm parents. I'm asking this baby is going to survive, is going to go out of this hospital. That's my first question. Whatever you do, what do you want for my baby? I am happy that you are doing a good care. You are one of the best neonatologists I know. But can I expect my baby is going out of your NICU? That's as a parents my first question. Then I will ask to talk to you later. This is my going. The baby is you will give to my baby later, and how many days you will take if you are going to give to baby to me. That's the duration. Next question will ask. Those are the relevant questions for the parents. In between, you do ventilation, you do CPAP, you do whatever machine you use. They don't understand many of the medical terms. But two basic questions they will ask. My baby is going to survive, is going to go out of this hospital. Please, can you tell me? Is guarantee there? So this line you answer. What do you expect to answer that way? Say, what is the chance of this baby's survival? How the baby is going to do? Expectation wise, is the baby currently doing well? Is the baby how many days going to stay? And what are things we are planning for the baby later? Broad sense, categorize and tell. Detail micromanagement, no need to speak to the family. They may not understand the medical terms. Please unmute yourself. Dr. Shweta, you muted or this system is muted.
Sir, currently your baby is stable. Baby is quite better compared to what we have seen on admission. In the last 40 hours, baby has shown improvement. So baby is doing well right now, and baby will require at least 2 months of NICU stay, at least 1.5 months at least, for a adequate baby, since baby is only 793 grams currently. So baby should gain adequate weight, and at least 1 month, 1 to 1.5 months time is required for NICU stay. And regarding the survival, in our hospital, there are 70 to 80% survival rates of 27 weekers. So the survival rates are adequate enough in our good enough in our hospital. So, and next is survival rates are there. And regarding further action plan, we will be doing a cardiac screening, and we'll be doing a neurosonogram subsequently on day 14. And we'll also do the keep a watch on nutrition of the baby. And yeah. So this is a comprehensive care, and kangaroo mother care further will be giving, mother should involve in the kangaroo mother care. And yeah.
Are you aware of any principles of counseling, any framework, any system? Are you aware of? Are you aware of what is GALPAC? Have you heard of the term?
Greet, ask,
GALPAC?
yes, greet, ask, listen.
Because most of the time in the examination, it comes as a OSCE. Okay, so and in OSCE, you can score 100 out of 100, 100% of marks. But you need to follow that, okay, the GALPAC system. Greet, ask, listen, praise. Okay, all that format you need to follow. Okay, good. Nice presentation. Thank you.
Dr. Shweta, before going to the question, I should say, first of all, I should appreciate Dr. Sandeep and you both agreeing with the short gap. You become ready to present the ventilation case bedside, come the clinical presentation in front of faculties, in front of so many students. We agreed with a short notice. Thank you both the team of Marathali.
It's our pleasure, sir. And, we are actually thankful that you gave us this opportunity.
No, that's the routinely will come to everyone, whomsoever volunteer or without volunteer also to go across the country. The list is available to us from NNF. So this time we will send invite to everyone, every NNF center, if it not their volunteering also. But what I'm saying, agreeing with the short notice and presenting so well, I'm happy they presented well. There's always a learning opportunity. I thank Dr. Sandeep Kadam sir and Dr. Jagdish, both carried the first case of ventilation presentation when happened. And we further with different cases, we will learn the different aspects. We will learn volume guarantee in one session. We will learn patient-triggered ventilation, different modes in one session. We will learn the weaning and NIV, HFO and PPHN management, nitric oxide management. All the things that through the sessions we learn probably. So I'm saying, student, regularly participate, put your questions, put your queries. It stimulates the faculties also for speak more to guide more you. So I'm quickly taking few of the questions. I will hope Dr. Jagdish will stay few minutes, few of the questions he can take. I know his prior commitment, he is also going, he is going to join somewhere else in the meeting. Dr. Sandeep, I will request to stay a few minutes, so the questions you can take as a moderator. So I will quickly ask. So what Dr. Jagdish asked, the previous questions, are the extension of that on student, trainee probably, or a neonatologist, I don't know. We don't know the identity here. Dr. Kushwant Kaur, see, it asked one question here. Post-extubation for a newborn babies, which is better? CPAP or HFNC? Dr. Jagdish asked, which is better? NIV or CPAP? Now the extension to that question, CPAP or HFNC? So anybody can take the question. So I will now put the question in this format. Extubated, NIV bar CPAP bar HFNC. How to choose it? Either Dr. Jagdish, Dr. Sandeep can guide the students.
Yeah. So suppose this baby, we always try to put the baby on a non-invasive mode of ventilation. So when the sensorium is not good, or the baby has some intermittent apneic episode you are expecting, so clinically you can put the baby on NIPPV. But as per the study wise, NIPPV versus CPAP, so the studies from the Bhandari et al., so they told that NIPPV has better reduction of BPD as compared to the CPAP. But again, the groups who are going with CPAP, they also tell that CPAP is going to be beneficial for the BPD. So for me, actually, I used to choose from the clinical point of view, I'm telling. So baby who is having a depressed sensorium, the baby is just gradually your shock is there, you are weaning from the inotropes. So better to keep the baby for some time on NIPPV. Once the baby is stable, spontaneous respiration is good, inotropes has come down, then only you switch up over to CPAP. Regarding HHFNC, so that is as a primary mode of support for the babies, it is not that good. But post extubation, you can plan for HHFNC, but better to avoid for the babies who are less than 28 weeks because the chances of failure are higher. But again, there are contradicting study in the recent NEGM study they have published. So there is no much difference between outcome between CPAP and HHFNC. But issue with HHFNC is that the sister has to be there by the bedside because most of the time we see the nasal prong is out. So in that actually HHFNC is not getting delivered. So if your team is very strong and monitoring is very strong, then you can try with HHFNC and it gives equal result as CPAP. But I personally don't prefer to put any baby on HHFNC less than 28 weeks even as a primary mode or as post extubation. I'll prefer CPAP. Okay, so but there are better evidence. Not only I can tell the better evidence what it tells. Sir.
Dr. Jagdish, I agree with your inputs, but before my concluding remarks, because every question I will probably try to conclude, taking inputs from you people only. But before that, I will request Dr. His opinion about when the student or a practitioner, a neonatal is standing in front of the baby, planning for extubation. A lot of things they plan. This baby is anticipation first. Before the planning, the anticipation starts. This baby is going to fail or to be successful. Accordingly, the plan. So the plan may be different. One size won't fit to all. The plan depends on the size here, I say. Size means size of the baby. A 24-weeker baby, I'm extubating. A 32-weeker baby, I'm extubating. So there's one model doesn't fit to all. There's depends on the size of the baby is smaller. Which day I'm extubating, this all will start. I will conclude that. But before that, I will request one conclusion line from Dr. Sandeep. How you will choose? You are today planning extubation. How you choose for your baby? And IV, CPAP, or HFNC?
Just like the way Dr. Jagdish said, I would like to put it in a different way. I would see why have I intubated this baby? Apart from the gestational age as one of the things. A smaller the baby, I prefer NIPPV. A little bigger baby, CPAP. Probably a term baby, HFNC. But also, the reason why you have intubated also matters. Whether it's a compliance issue or is it an oxygenation issue. A baby who has a compliance issue, I would definitely prefer NIPPV because you'll be able to provide higher MAP. And the chances of extubating is failure is very lesser. And when you have a privilege to extubate even with a little higher setting, in case if you're able to provide the same amount of very closer map through your non-invasive ventilation. Of course, there are a lot of newer studies like what Dr. Jagdish said. A CPAP can be given as high as 10, which my personal experience, I haven't used it. So that is almost like in a NIPPV, I'm trying to give a little higher map compared to your CPAP without much of a issue. But with a higher CPAP, probably the newer studies might come up where higher CPAP may be as equivalent to NIPPV. But my take would be, if there's a compliance issue, think of CPAP or NIPPV, preferably NIPPV in a smaller baby. If there's an issue in terms of your oxygenation, yes, you can extubate it to HFNC. And when it comes to term babies, they are not really comfortable with NIPPV many of the times. The comfort of the baby also matters. So at that time, HFNC can be preferred.
Sandeep? Sandeep, anything you are continuing or?
I'm done, sir.
So both of faculties perfectly fine. For the student's sake, I will say you consider as a practitioner the CPAP is the standard. When your anticipation is high for a failure, I will say what are the reasons? Many reasons are for anticipating a failure. You go for NIPPV, your success rate or prevention of re-intubation will be lower in NIPPV. Well-formed facts and studies are there. So if smaller babies, very small babies, very disease severity high, and you want to extubate earlier, probably NIPPV. But for the students on guidance, I will say, an IJP, an article published by Dr. Srinivas Murthy and Dr. Rajendra, both of them they reviewed well all the NIPPB or CPAP or HFNC, how to choose. They've given an algorithm approach for students learning from Indian Journal of Pediatrics 2021 probably. So they have a review article very well documented with all the evidences, keeping the CPAP as a standard, sick babies, small babies, NIPPB, a 32-weeker, 32-weeker, 31-weeker, 34-weeker, above 30-weeker, a reasonably moderate RDS I treated and extubated. I can put HFNC also. A 33, 34-weeker, why to choose a higher mode of ventilation without engaging a ventilator, without engaging a higher setting, we can go for a lower setting and easily. The HFNC, we know the advantage, easy to handle, can be seen, monitoring will be easy, trauma will be less, lot of advantage. So the across spectrum of the disease, we have to choose differently. For students' sake, I will ask, refer the article, you will get a clear idea, taking the evidences, using for practice. That will guide you. That's with concluding, I will go to the next sentence. Next question. Somebody asked ILCR 2023 update revision, please, sir. So that's a recording is available. Recording we will try to share later. We did a detailed discussion from the ILCR Society associate member. Dr. Bir Raghavan was the faculty. Can he discuss in detail from 2020 publication, 2021 advance, 22 advance, 23 advance, 24 January advance. We analyze all the advances. The recording is there available. We'll give. You want to go to the current recommendation, 2023 November in American Academy of Pediatrics Journal, it is there, the current recommendations. You can download and see it's a free copy. But all the things recorded, probably we can give the recording to you and share in the group, the NOEL group some days. That's probably answer the query. And one question I asked beginning, how the deferred cord clamping gestational age specific. I will just detailed discussion is there. I will one practice point, I will share it here. Above 34 weeks, the guideline was previously given. If delayed cord clamping or deferred cord clamping possible, go for 60 seconds. Not possible, now you can opt for a intact cord milking. That's little clarity above 34 weeks. Below 34 weeks, below 32 weeks, there was no clarity. Current guideline says up to 20 weeks, 20 weeks, not possible. The delayed cord clamping, you can do intact cord milking. Below 28 weeks, don't do. The harm is more than the benefit. That's the current one. Additional point. Detail you can go through the guidelines. So I will close that point there. I will ask another important point probably. What everybody is asking here. One question I'm missing probably. That's the rescue surfactant. The same question asked, Dr. Jagdish asked during presentation. Rescue surfactant in labor room is recommended or not? And what is the indication for the same? So little clarification. Dr. Sandeep can take the question and Dr. Jagdish can clarify.
So there's no role of any
Labor.
There is no role of any prophylactic surfactant. But when baby is intubated in the delivery room, and if you are unable to ventilate the baby and if the saturations are low, you can consider giving delivery room surfactant also. So if you have a delivery room where you have the facility to ventilate, you have the facility to provide a surfactant under a very strict asepsis measures, if you can maintain that, then definitely surfactant can be given in the delivery room in these situations.
So some of the extreme small babies where we are thinking that the maybe pulmonary development is not adequate, but we are intubating to rescue, to avoid higher setting delivery room without steered coverage, extreme small babies. But there also, when we go to the protocol, 22 weeks to 25 weeks, those are the extreme small babies in any context. They say, unless you are stabilizing the baby, unless you are confirming the ETT position right, don't try to push some of surfactant bolus into the lungs in the delivery room. Lot of disadvantage there. There's physiological disadvantage, practical disadvantages. Practically, if you want to confirm the tube, putting to single side, the right side or left side, most of the time it goes to right side. The volume you are ventilating will ventilate the right lungs dominantly. The surfactant bolus 200 milligram per kg, Curosur for 100 milligram per kg, Servanta, whatever we're using standard, that whole will go to the right side. It causes more harm than the benefit. So 22 weeker to 25 weeker, the guideline specific stage, confirm the position, then give. And 25 weeks onwards, 26 and 27, we know they always stabilize the baby, clear little fluids, give PWP, recruit the lungs better to the FRC, use surfactant, same dose will work better because the distribution, volume distribution is much better in aerated lungs rather than a fluid filled lungs in the delivery room. So clarity in physiology, recommendations are very clear. I hope both the faculties will agree not to jump to the surfactant in delivery room, stabilize by CPAP, stabilize by ventilation, use when the baby is little stabilized with lower pressure, lower volume, probably we can put surfactant in the rescue surfactant in the NICU. Any other point? If any of the faculty will add on, then probably will happy to take.
Just sir, only the European RDS guidelines they have mentioned in the last year 2022. So if you are intubating in the baby in the delivery room less than 20 weeks, then you can give a prophylactic dose of surfactant. So they have recommended, but most of the centers they don't practice. We also practice to be baby to be stabilized first and then give a dose of surfactant. But that is a recommendation is there in the European guidelines.
So thus we have to discuss that to consider in the some specific babies should not practice. We should differ because physical background is very clear. But to consider in the if antenatal steroid not covered developmentally, we know the very extreme premature, probably we can consider. Those words should be there. So people should not think there is a no, there is a possibility, but that's not recommended. So I will clarify one question. Probably all will clarify. Dr. Sweta during presentation told volume guarantee for this baby 4 ml per kg they have taken. One of the question came here. Two questions of volume guarantee. Is the volume guarantee mode same in the edge PRVC in MACWE ventilator? That's one question. Second question, how to ensure volume guarantee mode? A circuit takes a lot of dead space, an extreme preterm with the weight of 790 grams, volume 4 ml only. So how to answer those two questions? One is, I will answer one question to make it very simple. If you are using different ventilator, the terminology, the nomenclature is different. The volume guarantee, which commonly used in dragger system of ventilator, VN500, VN600, Babylog, is different. If you go to SLE, that's known as TTV plus. You will go to MACWE, it is written PRVC, pressure regulated volume control. In SLE, TTV, targeted tidal volume plus. If you go to a Puritan Bannett, is VC plus, volume control plus. If you go to a BARD system, it is different system. They will say the VAFs, volume measured pressure support. So various terminologies principally same. So theoretically they are same. Little difference in the depending on the flow sensor. But the next question I will come clinical question. Both the faculties I will invite to answer the question. If such a small baby 790 gram, I'm going to use 4 ml per kg or 4 ml. That's the question from the student. They're anxious that the circuit is such a big circuit with so many ml of dead space. Can we use with 4 ml per kg ventilate a small baby? That's the question. How to answer that question? Clinical question, please guide the students.
Hello. Suppose if you have a flow sensor in the machine, so there is no problem of giving 4 ml per kg. But if the flow sensor is not working, then it is difficult. And the flow sensor will actually, they will monitor how much amount of tidal volume you are giving. So it won't be difficult to give 4 ml per kg tidal volume when you have a good flow sensor.
And with each, I just want to add, with each change in the flow circuit, you calibrate your flow sensors, as well as when you connect it, you will definitely able to give 4 ml per kg. With the newer ventilators, where the least tidal volume which you can deliver is 2 ml. So 4 ml per kg is possible in our new ventilators which are available. So there shouldn't be any difficulty in giving 4 ml per kg.
So one inputs from my side here, though I like one group of ventilator company which probably we use for years together. That's one of the finest flow sensor. This question related to the flow sensor. The flow sensor which previously used, the dead space was 1.6 ml. Absolute ml I'm saying. 1.6 ml for a 500, 600 grammer baby is quite a big dead space. But current generation, what existing in Indian market also, they are having dead space of 0.9 ml. So 0.9 ml can be a good amount. 1 to 1.5 ml per kg for a 750 grammer or 500 grammer, it may be 1.8 ml. So for that reason, they say absolute 2 ml, when it comes to absolute 2 ml, means a 500 grammer 4 ml per kg is 2 ml. That's maybe this all the machines, including SLE, including the ventilator dragger system of ventilator, including acutonics below 2 ml is difficult because already 0.9 to 1 ml dead space is out. So for that, I will say the students can refer Martin Kessler's article So, or the Dragger manual also they can refer. Smaller the baby, the recommended says can go to 6 ml per kg to 5.5 ml per kg. In the babies who are 600 gram or smaller, extremely ridiculously small babies. Though ELBW is extremely low birth weight baby. The newer classification for this ventilation they have done ridiculously low birth weight baby, who is less than 750 gram. Those babies probably 5 to 6 ml per kg will calculate reasonably. 3 ml or more than that will come. But what the fear, the student saying that it's such a big circuit, nothing to worry, because the flow sensor is attached to the baby end, patient side in the close to the AT tube. So the measurement, it bypasses the circuit, it measures at the baby end. The flow sensor or the pressure sensor, trigger sensor, which in the machine, in the servo side, like some of the older machines, when the flow sensor inside the machine, beyond the circuit, there it is a tricky situation. But current generation, all the machines use the flow sensor in the patient end. So they compensate for the tube and they deliver whatever desired volume. But the flow sensor will have again that's to be compensated. So smaller the baby, 6 ml per kg. Moderately small babies up to 1 kilo. To start with, 5 ml per kg is relevant. Above 1 kilo to 1.5 to 2 kilo, 4 ml can be standard. Again, disease-based, mechanism aspiration, RDS, pneumothorax, CDH. All recommendations pretty well in the book is there, ventilation book, Goldsmith or Martin Kessler article. I'll suggest go through that. You will get a clarity, put the table, and no fixed cookbook again. Whenever we're talking about ventilation, no cookbook. No baby likes whatever recipe we are giving. So what I will suggest, babies are different at different ages. First day baby and 25 days baby, they are different. Different disease progress. Severity of disease initially later. Baby stable, later deteriorated with developing sepsis or BAP. So baby's condition changes. A PDA on treatment, pulmonary hemorrhage, suddenly pulmonary edema, the baby will behave differently. So don't go for a fixed regime, fixed prescription, depending on the disease. Discuss with your faculty, the consultant who is experienced to understand the physiology. So accordingly, we can choose. But the standard guidelines are available. You can probably go with the standard guideline 4 ml to 6 ml, depending on the baby's condition. That's probably my take on that volume.
Sir,
and
Dr. Nalini.
Dr. Jagdish, please.
Yeah, I want to leave. Actually, I have to join that class.
I understand you to join some program. Thank you very much. Thank you very much for your inputs and active participation. We will see you later in some sessions again. Thank you very much.
Thank you very much, sir. Thank you. Thank you, Sandeep.
Thank you. Thank you.
Dr. Sandeep, we have to close now because it is to 9:30 cross. So
Yes,
what I will say quickly, I will say all the differential diagnosis when the first dose of surfactant fails. Dr. Sweta highlighted. Students ask some question. I don't think we should go for again because Dr. Sweta clearly highlighted if the surfactant not responding, baby's RDS baby, what are the differentials, and Dr. Sandeep Kadam sir has guided. I won't go for one or two questions, relevant questions asked, actually practice questions may be bothering many. Repeated nasal injury during the NIV or CPAP, face mask injury, somebody is asked how you manage normally. Dr. Sandeep, can you guide, because that's maybe relevant to all the trainees.
The first thing is choosing the right size of the mask or the prongs if you are using. You should make sure it is snugly fitting, but it shouldn't be too tight. And second thing is you have to make sure the movements are not much. So carrying the baby in such a way that there are not many movements is very important. The main important factor is the nursing care. You should have a very trained nurse who regularly checks onto that and make sure you have a protocol where we have like every 4th hourly you monitor, see for the injury, make sure you refix the mask and use the saline nasal drops so that the humidification is appropriate, and always use a heated humidified circuit so that there is no nasal crusting and causing injury. And one more thing is about using any membrane. So you have any kind of a barrier device which prevents injury. So here we use deodums, but you have pre-built cannulates also which you can use. So these are some of the measures with which you could decrease nasal injury.
So the question was a little specific. They use one of the material. Then what any different materials available now to decrease the injury? So practice to gauze or duoderm they use. Probably I think this material is not important. The practice points which Dr. Sandeep guided, that's probably more relevant. More 1-to-1 nursing ratio or 2-to-1 nursing ratio, monitoring more frequently and more vigilant for monitoring the skin injury. That's probably protect us from the injuries rather than which material we're using. The duoderm or hydrocal materials many people use. We also use same thing. Well, material same, but the care should be little more vigilant, more careful we should be to decrease the injuries in the during CPAP or NIV. One quick question I will ask Dr. Sweta. Dr. Sweta, are you there with us?
Yes, sir. There, sir. There.
Quick question, 2 or 3 relevant questions came. I think you presented well. So presented well, you answered well. The presentation was focused. So I'll ask you a question from the audience. They've asked, if you given 1 dose of surfactant on CPAP or during ventilation, these are 2 different questions. I'm classifying it. Baby is on, you've given Insure Lisa, given continued CPAP or NIV. Second dose of surfactant, how to choose. A baby ventilator, surfactant use ventilated. Now during ventilation, how to choose the second dose of surfactant. If you are choosing surfactant, what should be the minimum duration after which you can repeat the second dose surfactant? That's the 2 different questions came. Please clarify those all the things. So otherwise, Dr. Sandeep is there, will guide us.
Sir, firstly, after giving first dose of surfactant, if the baby is connected to the CPAP and still the baby is requiring higher FiO2s can wait up to 4 to 6 hours, the baby is still requiring higher FiO2 and distress is worsening, then baby will require second dose of surfactant in where if the baby is on CPAP or NIV mode without intubation, then we have to consider intubation and give second dose of surfactant. But if baby is already intubated and still requiring higher FiO2s and not able to wean down on pressures and X-ray suggestive of RDS picture and the distress is worsening, then we have to rule out the other causes and think about giving a second dose of surfactant.
This is little objectivity the student expect, Shweta, because higher oxygen means you may think 25 is higher, somebody may think 60 is higher.
Greater than 30% FiO2 requirement after 6 hours. Even after 6 hours of administration of surfactant is a worrisome, and we have to consider second dose after ruling out other causes.
So when you use first dose, the 30% cutoff on CPAP, first dose. Second dose also 30 to 40. There is no consensus. Some says 30, some says 40. After the adequate recruitment of the lungs by 5, 6, or 7, whatever the up to 8 also they have written in protocol. 6, 7, 8, whatever the CPAP you are using, if you recruited the lungs well, and we require more than 30 to 40% after first dose, 6 to 8 hours after, and some surfactant preparations are 6 to 12 hours apart. So there's a 6 to 12 hours, the range is there, but the cutoff for oxygen is FiO2 for 30% or 40% with adequate recruitment of the lungs by X-ray, which is 6 to 8 rib spaces by using either 5, 6, 7, 8, whatever the CPAP as per the unit protocol. That's the answer probably on CPAP. Coming to ventilator, I have given surfactant. Now continuous ventilation I am doing, and 1 dose is over. When I will take the call for a second dose? I'm ventilating already, not on CPAP.
Sir, even the after giving first dose of surfactant, we can wait up to 6 hours. Even then the pressures are, the FiO2 requirement is more than 30%. Then we have to rule out the other causes of higher FiO2 requirement, like if there is any pneumothorax or is there any pneumonia or other causes have to be ruled out, and then one X-ray to see the ground glass. If there is still homogeneous opacities, uniform lung disease, then we have to consider second dose of surfactant.
So X-ray will guide us. We have to do X-ray to do second dose surfactant after 6 hours. So you are suggesting if I will repeat within 6 hours to 8 hours X-ray to decide?
Yes, I think we should. If baby is worsening, yes, we should.
If I'm suspecting pneumothorax, can I do a better some quick bedside tools, or can I use non-invasive tools or non-radiating tools to know the pneumothorax is?
Chance illumination test, sir. We can.
Or ultrasound lungs also I can do if I'm experienced. The unit is experienced, they can do that. But rather than exposing to a radiation, because already you must have diagnostic X-ray must have done. And if intubated again, tube related again must have done. Lines tube related again within 6 hours you are suggesting. I'm little worried. Dr. Sandeep, do you agree to repeat a X-ray to do the second dose surfactant, or some clinical criteria we can use and guide the students?
So first thing is, first we need to know whether your first dose of surfactant has responded or not. So before you give your second dose of surfactant, the indication is that you should have some reduction in your ventilator settings. There should have been some response to your RDS. Because why are we giving second dose of surfactant is to think whether no, you need to make sure that you're not considering any other disease apart from RDS, because the efficacy of your second dose of surfactant depends on what is the response to your first dose. So if you have a response to your first dose and then there is a further again worsening, in that criteria, what we use generally here is 40% as a FiO2 criteria. So you have started 30, and if your FiO2 requirement again goes back at 40%, within next 4 to 6 hours, we give the second dose of surfactant.
Absolutely. So now ventilation regarding the guidelines are that duration question, if you ask the students, for them, again, 6 to 8 hours assessment and 6 to 12 hours, so we can give surfactant. As Dr. Sandeep told, clinically, I won't go for a X-ray, but I try to rule out all the secondary causes of surfactant failure. Once I know it is HMD, which requiring probably larger dose of surfactant, the first dose didn't work out, then I will go for a second dose. Second dose regarding 2 criteria are there in the book and the protocol. If the after ventilation, if the MAP requirement is more than 8 in a small baby, LW baby, or the FI2 requirement more than 40%, then I should go for a second surfactant if there is HMD. The 2 criteria only. After assessment 6 to 8 hours, if I am using more mean area pressure, sometimes I will use 25/6. So suddenly what will happen, the FI2 will come down. To limit that excess use of pressure, there is 2 guidelines are there. MAP 8 above or FI2 40 or 30 above, different guidelines says. So that if 2 criteria is fulfilled, probably I will go for surfactant second dose. That's probably clarify the question. So again, I thank all the participants till now. There are 100 above students still participating, still waiting for our answers. And but I have to time constraints. I have to stop the session here. I will thank Dr. Sandeep. Again, before concluding the session, please, any opinion, any suggestion, or any message to the audience. Dr. Sandeep, I will invite you to put the message to audience, then I will close the session.
So first thing is, thank you, Nalini sir, for giving us this opportunity. And it was a short notice, but I would also congratulate Dr. Shweta for presenting it well. So she had to do it, within a day, she had to prepare for it. And these sessions are really good because it also exposes the students to different kinds of examiners, different kinds of questions they'll get it. And also as a learning curve, for us, everybody has a different view about different aspects. Though we have protocols, we have guidelines, the way everybody thinks is very different. So as a student, when we are in a one unit, we just are knowing only our teachers, what they are teaching us. But these kind of sessions will expose us to so many different views, which will actually open up so many views of how to manage each individual things. And that curiosity in a student will actually develop with this. So it's a wonderful platform that which helps a student to learn a lot of things. And the other thing is, sir, I have only one thing. This link to this is actually not, sir. I mean, not everybody gets it. So I really don't know. I miss a lot of sessions because I don't get the link. So I think that needs to be sorted out in this, sir.
So actually, there is a student group from the NNF fellowship group, NOEL group. The doctors from probably previously somebody was handling, now Neetu, the office bearer from NNF India. They have created a NNF NOEL group. And there the posting happens each week. The student gets, but as a faculty, even though I am conducting NOEL as a vice chair for last 2 years, I don't get the link officially. I created link. The officially I won't get, never I got till now. Unless I am a moderator or a faculty that particular session. That's the format what to do. But all students they are receiving. To all the students from every organization, once you registered your number for fellowship, you are included in NOEL group, and NOEL group posts there. So every one day before or same day we post. So that's a little tricky. So I was also a little worried. I am guide, I am faculty member, but I don't get the link. So we will request them to send to the center faculty at least. The center director, who will put a director group. So center director, faculty also will receive, they can circulate among themselves. I will just request once to the NNFI. Because I don't post, from the office bearer they post, so that's a little tricky situation. A recording session also somebody requested from to get recording. Previously recordings were code, one platform used to store. Now some vendor issue. And so new president we have requested to sort out that. but all the recordings are available with Mateen, with the office bearer for this whole program. So I will request, see if he can deposit to NNF and in a platform, student can access that, because somebody was asking previous sessions questions. So we saw we can provide that, but through the office bearers. And I will thank again all the audience, training and participants, both the expert faculties, Dr. Sandhi Kadam, Dr. Jagdish Sahu, and moderator faculty who initiated the session, who continued till the end, and with a lot of clinical messages here. And not the least, or at least I should conclude the session after thanking Dr. Sweta, who completed the session well, taking us to the bedside, showing the baby, and covering the baby's detail in the PowerPoint format. We learned a lot. Before closing the session, I will request again the student, we always remember in neonatology, less is more. We may learn a lot of things to do, but how to choose not to do, and when required to do the minimal thing to help the baby. So that's the learning point in neonatology and ventilation specifically. And I request the second point, I will again request, participate happily, because your attendance recorded by the office bearers, and they have decided, not confirmed, but they have decided to take the attendance to 85% minimum attendance to appear for the exam. That's the decision. Only officially they will convey, but I request participation is a learning platform. That's not exam. And each 4 sessions after, we will do a whole session of 1 hour OSCE on that system. If respiratory system, we'll do a respiratory OSCE. The cardiac system, we'll do cardiac OSCE. In a preterm module, we'll do a preterm OSCE. Like that, we will complete. So it will be helpful for all the students presenting the case, discussion practice points, OSCE examination on full day session, we will put it. And there we will invite for participation. So request all, spread this message and link to your fellow colleagues, participate and discuss. So it's almost throughout the year, it will run till your examination. So definitely it is going to be helpful for you. With that, thank you all. Good night. Goodbye.
Good night, sir. Thank you, sir. Thank you.